Good afternoon, ladies and gentlemen. Am I audible enough?
Yes, you are.
Thank you. So good afternoon, ladies and gentlemen. Welcome to this webinar. This webinar is proudly sponsored by KNH together with the Society for Quality Healthcare, Kenya. Permit me to introduce someone special, a mentor, and a champion for quality healthcare, Dr. Lydia Kutoi, who is a Kenyan, a patient safety and quality of care expert. Her background is in clinical and later transited to support operations at the healthcare quality division at the Kenyatta National Hospital. Dr. Lydia has supported the national level efforts in developing the national patient and health worker safety and quality of care policy. On the African front, she has been recognized by the Patient Safety Africa, PSA, for her contribution to patient safety, including the work to develop a quality and safety curriculum for healthcare workers. These are efforts made in contribution with Acquire, the African Consortium for Quality Improvement Research in Frontline Healthcare, Society for Quality Improvement, and other independent quality and safety experts in Kenya. At the global front, together with other patient safety experts, supported the drafting of WHO, developed the documents forwarded towards the February 2023 Patient Safety Ministerial Summit that happened in Maastricht. This included the operational guidance, ensuring patient safety during pandemics by the WHO. She is the founding president for Society for Healthcare Quality, Professional Multidisciplinary Healthcare Workers Body. Lydia has academic interests in patient safety and has published several opinions and peer-reviewed articles on quality of care and patient safety. Permit me to allow me at this moment to be able to welcome her, to be able to share her screen. My name is Milan Ochieng. I'll be your moderator for today. Dr. Okutoi.
Good afternoon, colleagues. Am I audible?
Good afternoon.
Can you see my screen? And is it on screen share?
Yes.
Thank you. And thank you, Milan, for that elaborate introduction. I'm humbled to be with all of you this afternoon. And on behalf of KNH and SHQ-K, Society for Quality Healthcare, we are glad that we're able to take on this series on quality and safety. And so I'll just be laying an introduction to it, and we will have a series of others, I think maybe 4 or 5. And we also are drumming the beats as we go towards the World Patient Safety celebrations that come in September. So I will go right ahead to the presentation. I hope my connection is clear. Milan, is it, am I clear, or Mandela?
Yes. Yes, yes, very.
Thank you. Thank you. I don't know how recent you visited a care facility, and whether it was your loved one or a friend, or you are visiting somebody who is receiving care, what your experience was, because healthcare is a common good. And so at one point or another, we or our loved ones interact with the system. And that is a time when we ask ourselves, did the care I received, was it fit for purpose, for what I intended it or what I needed it for? If that is how we could look at what our need was at that time. And so, Milan, you being the moderator, you will pick for me at least 4 items that will be mentioned. If you could just type on the chat box your last experience in the facility. What did you like most about it in terms of addressing the need that you had? And did you have any concerns? On my end, today I had to have one of my children be seen in our facility. And I think other than the waiting time to process the payments that took a little longer than expected, I think I liked the place was clean, and the doctor was able to share information, because this particular visit, what I needed was information for how to take care of this child. How do I ensure that they are healthy and that they don't have frequent admissions? And so I went for information. As much as I am a doctor, when I'm a parent, I need to also approach the system in a manner that I should benefit from it. And so I clearly took the role of a mother, and the information came. Of course, there's a little bias because I could ask more because I know a little bit more, but I truly needed some reassurance, information, and just care. And I should say that I wasn't disappointed, and I wish every other patient visiting a facility got that some information if they so require, if that is their need. Milan, anything mentioned on the chat box? Any 2 or 3 in terms of what, for me it was information and I got it?
Yeah, so one says that they took her mom to a consultant a week ago, but was surprised that she was quick to dispute. Another one says, good afternoon. This is basically about CPD. So yeah, one says reception was friendly. Yes.
Mm-hmm. So that one has mentioned they're friendly, and anything that maybe you are not happy about, because it will also show what your need was and how we did not fit in that position to, our services were not fit for purpose at that time. So the friendly, that one I've picked.
So far positive comments, yes.
Okay, even negative ones we learn by being this, like the waiting time for payments. I think it's quite something for, I mean, in my various interaction, the quickest way is to pay cash. Then you won't wait for many things. But it happens that at times you don't want to pay out of pocket. And then also at times also Kenyans, you may not have an option of having a cover. Some people may not, a good number of Kenyans. So it means waiting for whatever, whether you're waiting to see the doctor, that takes a little too long. And my wait, I think, was a bit explained. We were told, oh, there are this number of new patients, and so it will take this long. And so just by waiting and knowing I'm waiting because they I'm sorry, I dropped. Am I back?
Yes, Dr.
Great. I'll just take a second to change my router to something that may work better as I share the screen once again.
So, Dr. while you dropped the few comments that have come.
Okay.
Yes. So there's concern about delay. There's concern about some doctors making sexual advances to patients. Providers actually denying that they actually saw a patient a week ago. Yeah, largely delay, bad attitude. Yes, bad reception, interference. Yes.
Wow, some of them are very are of a different tangent that to do with professionalism. Yeah, so we may not be able to address that, but the ones about the delay and attitude, they are felt. It means the system was not as responsive as it is supposed to be. And so that is regrettable. So it means that next time you go there, you are not sure whether you will get what you so desire or what fits the purpose. Great, thank you for indulging me in that. So we will just have a brief discussion on what quality and quality improvement is, and then we will highlight a few principles on what makes quality improvement successful, and share on models and what is the benefit of quality improvement, and go ahead to share some resource links that maybe we could use to investigate or find out more about quality in terms of links of resources that are available on open source. So I think that will be our approach. And so what is quality improvement? Quality improvement is the delivery of healthcare with improved outcomes. Our aim is improved outcome. And this definition has come from a mixture of many, many definitions, but lowering the cost has become a key thing in the West, and it is very important even here in Kenya, ensuring that there are good outcomes, but we are getting those outcomes at what cost? If it's possible that at lower cost, and then also to continually redesign our work processes and systems. And we use methods that are known, systematic change methods that are acknowledged as these methods or these strategies are known to work. And also another outcome is to have a patient experience improved, or in KNH, our logo, our mission is to optimize patient experience. So whatever term you use, the patient experience should get better. If I felt not safe, then even if you think you did the right thing, then there is a challenge there. My experience as a patient through the system should be good, and the system should endeavor to improve, or to look for any outlier experiences that aren't as good and work on them. And so the outcomes could be in different fronts. They could be at the technical level, or could be at the level that even the patients, this patient experience is about outcomes that are felt, the responsiveness of your system. And so those are the key words that we look at when you're talking about improving the quality of care. And so quality improvement by itself is surrounded by other terminologies. So allow me to go to the Durant's trilogy, that there are other aspects that indeed we have to say, what does goodness look like? How are we defining the needs of the customer? What is our goal in this process? And what have we prioritized as what we are working on? And how do we know that there are gaps? That now comes to quality control. So when that is sound, it gives a basis for quality improvement to be strong for now designing and change and getting better in performance to happen. And QI uses, as we say, specific strategies, what is called the science of improvement. There are specific strategies that are used to know that the change we have made is indeed an improvement, is indeed for the better, because you could just change and not make things better. There are few terminologies that usually come across, especially for systems that are well established in terms of, like, they have a quality management system or they have a governance structure. So the terminologies that are used by themselves, they are synergistic to all quality improvement effort. For example, performance improvement. In KNH this season, we've finished the financial year, so we are about to start, we are in the process of appraisals, that is performance management by the strategy department. By itself, those are quality programs, but they are not per se a quality improvement of the health services, but they synergize because they are administrative performance measures. So you may do very well administratively, but at the same time, that has to have an impact on the services that are provided. And so the nuance that is different between performance improvement and quality improvement is the aspect that quality improvement, we are talking about the care processes, the people in the middle of those care processes, that's both the patient and the staff, that there is improvement of those processes. While in performance improvement, we more or go to the people, that so-and-so you are supposed to do 10 cesarean section, and we tick that you performed 10 of them. Now in improvement, we will say, what is the quality of life for the people you did the cesarean section? What was the quality of the mother? What was the timing? And so in improvement, we look at the processes that support that aspect. Patient harm is patient safety is an item that is one of the domains or key aspects of quality. It is just put aside for affirmative action, that we should not forget that care should be safe. And so even patient safety, the idea of harm reduction is an improvement of quality. When you reduce the risk, you reduce the number of redos, reduce the hospital-acquired infection, then that in itself is you are improving the quality. But we have affirmative action towards patient safety. That's why it usually comes up, somebody saying quality of care and patient safety. But essentially, it is an aspect of quality care. Then there's regulation. In regulation, regulatory processes, for example, having been allowed or licensed or certified to do a certain procedure or to run a facility, you're complying to some set processes and procedures, and this is set by law. And so it has the nuance of a common good. It is to protect the society. So it's no longer just professional, but it is to protect the society. That's why regulation is also important, but it is not per se in itself quality improvement. So it makes the basis for quality to happen, that this hospital is allowed to have an X-ray department that has walls that are reinforced. And so when we look at the other things, they have met their regulatory minimum standards. So regulation also plays a benchmark. And so when there are gaps in regulation, it's an opportunity also to improve on that so that we meet all the regulatory requirements. And then, of course, there are what we call QMS, quality management systems, for example, ISO. So those are processes that are identified for a specific fit, like for hospital, and procedures are developed, and controls and documentation, and they have a regular way of assessment, internal audit, and ensuring you're complying to what you said you will do. This is how a safe process in admission looks like, or a safe sterilization
Hello, Million. Is Dr.
Oh, sorry, let me see where. Great, so we're there. I think we are just linking that clinical audits, research, service evaluation, they provide fodder for quality improvement. They are a little different. In mainstream research, you're looking at, you're generating knowledge that can be generalizable in some way. And also you're looking at a certain p-value. But in quality improvement, we basically just look at opportunities to continually get better. And so we only measure what is necessary for that change, because the very nurse who is working, treating the patient could be the same one or the same doctor who is supporting quality improvement. And so it's not an end to in itself. In quality improvement, measurement is not an end to itself, but it should create some change. I've put a quote, a link there, a book by Backhouse. They have a good understanding of what, I mean, they've written some good succinct information on this and how research, audit, and others fit into QI. And so we have many lenses for which we can look at safety. And the lenses could be the patient, the community. For example, NHIF, they're currently looking at the lens of value for money, that are we paying this service for this amount? The government could be looking at coverage. And so there are many lenses. However, when we just see, so what lens are we looking at this aspect of quality? It comes from some domains that were measured, especially in the early, I think it was in the early, in 2000, when we had a presentation by IOM on crossing the quality chasm. Because initially we're like, okay, so how does quality service provision, how does it look like? This is not an item, but it is care. What are the aspects that should be there? And so they came up with this acronym STIP, that care should be safe, should be timely, it should be effective, it should be efficient, and there should be no discrimination. Equity should be person-centered, and later on integrated care that is well coordinated was added as a domain. And so this domain, depending on the lens that we are looking at, whether we are the government or the healthcare worker, because even healthcare workers ought to be safe, then there will be opportunities of improvement. That is, there will be the items that are being looked at. For example, harm reduction, increase of coverage, increase of a package. For example, would want this amount of money to be able to give the package for school children. They'll be dewormed, they'll be given whatever, clean water, whatever is supposed to be in a package at community level. Then you come to the hospital, what are the packages and at what cost? Is there increased access? For the health worker, is talking about, am I having a safer working environment? For people who are marginalized, for people who are living with disability, when I come to the hospital, can I access the doctor's areas? Can I access the washroom? Or I have to use the washroom at home before coming to hospital? And now from the technical aspect, the healthcare worker, when they talk of quality, they're like, am I adhering to my professional conduct, and am I giving care that works? Am I using the protocols as should be? And for me, who's waiting at A&E, is there a reduction of my waiting time? Next time I come, I would want to take less. And so these questions who should be asking these questions? The patients will wonder, the individual healthcare worker will wonder. So it is a concerted effort. The person who should look at improvement should start with that person who sees the pain of the patient or of the system. Could be the manager, could be that nurse, like this can get better. I think if we change this process in this way, if we adapt it, then it is possible when people come for chemo, they don't come and start processing their NHIF on the same day they're supposed to have chemo. And so in some clinic in Kenyatta, the nurse is there just to clear that your NHIF is okay, your blood work has been done, and so you're set for tomorrow to come for chemo. So that is the person who thinks, how do I redesign? Because they have seen the pain. The person who is discharging at Malipo Center, for example, or who is at a cashier, and the patient has to have many documentation, is the one who can say this can reduce, other than the patient complaint. Of course, the patient's voice should be heard, they can complain, but we're trying to say that there are many perspectives and many lenses, and they all will lead towards a desire to address the gap. And the gap is addressed by some change. And that is what we are calling quality improvement. Okay, so I'll go to some key principles of QI. Just like an overview, because we may have opportunity to go through this in the next, in the series that follows. So first is that the primary intent of quality improvement is to have measurable change. So that means measurement is part of QI. There is no way we will know whether we have arrived at a certain destination if there's no measurable change, that we say we were here and we move to the other. And so that is a perverse concept in quality improvement. You don't just assume. You use data and you decide what are the mangoes, and next time you compare them with mangoes, and what are the oranges. So you decide the points that are being measured. Then you also have to appreciate that care is presented in a system that is complicated. Healthcare processes, together with the very patient, provides fodder for complex interaction. And so for you to address any difficulties that are there, gaps, it requires that we bring the people from various aspects, including the patient, including the staff. It means that you may involve multiple people, multiple players, maybe the ones on the ground, the ones in finance. So it is provided in a complex system. And so you require to have this understanding that a certain outcome, by the time a patient has come and they are disappointed with a discharge process that have taken 7 hours to be discharged. There are inputs that come into it, and there are multiple people and multiple steps. And so that needs to be looked at for you to understand how to address that challenge. And so we need to focus on the system, and we need to appreciate that there are processes that are involving many different people. And so you unpack each of them. Mandela, somebody, Milan, somebody had raised their hand. I think we can go to the end, or is it anything typed in the prior slide? Milan?
Yeah, I have not seen any question.
Okay. I think it was either Dr. Mwango or Grace Mwango, but we can get to the end. And if you have any questions, you can type them in the Q&A, and we will respond. Some of the members of SHQ-K and KNH quality are also on the platform. The direct ones they can answer. Thank you. So we have to be looking at measuring, and we have to think that outcomes don't happen by themselves, but everything is within a certain system that have complex interaction. And so we unpack those complex interaction, and that is what is called having a system thinker system redesigning so that we can identify the bottlenecks and address those challenges. The other key issue is to focus on the patient or on the people, and the people are both the patients, including the staff. Yeah, but the customer needs to be satisfied. So we have an internal customer and an external customer. If you have internal customers who are not happy, grumpy, it is difficult for them to satisfy your external customer. So both are equally important. And so they need to have a voice and they need to be part of the redesigning of the system wherever possible directly. But if not, their views ought to be represented. Then also an important principle is use of data. The use of data to make data-inspired decision. Data by itself may be hard and cold. However, when it is contextualized, then we are able to make decisions that will help the change happen. And these are in multiple fronts. The data could be to the frontline team for them to know, oh, this is how we are performing. And so we need to change. It could be to another much higher level team that you want them to fund, or you want budgets to be reprioritized for the purpose of your need. And so we need to have data-driven decisions. And the bigger thing is data-inspired decisions are very important. This slide is just to help us appreciate that the data needs to have a story. When it is data-inspired, we'll be saying, when we have multiple reopening, when we have increased SSI, that is the surgical site infection, we are making this mother stay here, maybe it is after cesarean section, and the family is going without their mother, the child is admitted to newborn unit. So this data of post-cesarean section, surgical site infection, it has a face behind. There is a family, there is an increased bill, there is this Jengo person who is struggling, there is this officer or somebody high up in the ranks who has now to spend time in the hospital instead of. So we need data, but it needs to be contextualized and it needs to tell a story, especially to the relevant people. And so we need to have our data inspire improvement. QI is more of a movement, a desire to relentlessly change for the good. And so storytelling using the data is a key principle. Then we come to focusing on teams. Teams bring multiple resources, multiple skills. It comes with resilience, and even the team leadership brings a very important dynamic. And so QI cannot be done by a single person. It is not an executive order, it is for complex issues. Because healthcare is held in a complex environment with multiple interaction. By the time a nurse takes a BD pack is a pack that has some few items for cleaning a wound or so. By the time they have that pack ready to serve a patient in a certain ward, it has been ordered for, somebody has had to sterilize, procurement had to buy the items. So there are multiple fronts of when we go for weeks without having enough BD packs. What happened? It is complex. So it is possible at a stroke of a pen, you would solve that problem, but it is possible that it could be much more complex than that, and it could be a different kind of issue that is affecting many other services. And so teamwork and empowering the front line, the person who is closest to the problem is the one who is able to appreciate that problem and is able to understand the vulnerabilities of that system more. And so as we look at the teams, we also empower the people closest to the process to support improvement by giving them skills in doing QI. Sorry, I have a rough throat, so I'm trying to sip as we continue. You'll bear with me. And so the issue of the frontline healthcare provider being part of the team and being enabled to think as a QI, to have QI skills, it is a game changer for institutions. Allow the teams to learn, to improve, and to have those hurdles to say, this is where we are, how can we change? And for them to know that they don't need to ask too much permission to change a process that is just before them, and the leadership to support that. And so this comes to the role of leadership in ensuring that these empowered teams at the front line can change the system, because they may understand the pain. There's something called the blind spots. As you go higher up in the organization to the CEO, the blind spots are multiple, but at the lower level, that's where the iceberg is. So it is important that the frontline teams are empowered. And what we have learned, the things that have changed, or what we call the islands of excellence in anything, should be scaled. When you have quality improvement and something has worked in another department, then it should be imported. That learning should be a system learning. When you do QI in a hospital, it is important that we share, so that we don't have one part being in Jerusalem and the other one being in another in Judea. We should be able to share our lessons. And when the residents rotate, when the doctors rotate, they will not say, when I go to this ward, I know I will get all the vitals taken, I will get ABCD, and this other one they don't. So it is important that we learn and we scale with the desire to adapt. It may not be adapting of one-to-one, but with some changes, you can adapt the lessons learned from place X to the next place. And so in summary, those are the key principles that I've mentioned. Some of them have a nuance of going towards what we call total quality management, but these are basically focused on what makes QI a work, that we are able to have measurement as our key indicator that we are changing, that there's measurable improvement, that we are focusing on the system and the processes, that the persons have a voice, the family, the healthcare workers, and we are using data-inspired decisions. We are telling the story of how this thing that is working very well has changed the life of ABCD, and how you, word X, you should adapt it. And then also we focus on the teams and empowering them, empowering the frontline and scaling up what works, adapting, allowing variations for the purpose of spreading the good work. I wanted to share something about the Kenya quality model for health, just to say that what we talked of the domains of quality, that even this model uses the key principles that are in quality improvement, but at the same time emphasizes on standards of care that works, evidence-based care. That's the Kenya quality model for health. And it's also customer focused. And it has the total quality management approach in it. And so just to mention that we have a standard and local standard that is fairly robust. It is not exhaustive. Like on matter safety and others, it may be a little of the safe care may have something more, JCI may have something more, but it is fairly a good standard. I wanted to go toward the quality models, maybe just to share 3 of the quality models. that we have the lean approach. Lean was developed, I think, by the Toyota. And in lean, the idea is making sure that the customer gets value, removing all non-value add steps in a process. And the principles involve defining what value is. What are the customer defined value? If customer value is not waiting for too long, getting warm food, we look at that, we listen to the customer. Then we map the process. How does the process that the customer how does this issue that the customer has, what process does it go through to reach the customer? And if there are gaps in the process, then we ensure that we create the flow to the customer, that the gaps that you found in the process map are addressed. What we call non-value add steps. In lean, we look at waste. So you see, is it waste in terms of time? Is it waste in terms of production? There are like 7 types of waste. So in the view of the customer, when you mapped the process, what the customer is saying is value. What is the process doing to bottleneck this from flowing to her or to him? And so you create the flow, and then also you establish the pool that when the customer wants a certain service, then they will receive it in their terms or in their request, not just when we are ready that we are pushing. So then we also look at what worked, that is pursuit of perfection, and continue to make it work. So in lean is addressing waste and making sure that we eliminate all non-value add steps and the customer gets the flow. It's been adapted to healthcare, and I think it has a good fit to the healthcare processes. And Six Sigma looks at reduction of defects and improving the processes. And it has a methodological way of doing a quality improvement process whereby you define also what your target, what your goal is, and what will you be measuring? As we said in QI, measurement is very important. And then we analyze, then we do the improvement, and we standardize, we control. So they have some similarities and a little bit of difference. So there's a new approach whereby it's called Lean Six Sigma, whereby they merge them. They use some of the steps in Lean to amplify, to make it clearer what this could mean, especially in service provision. Remember, Six Sigma and Lean were initially for manufacturing. So it is an adaptation that we are using to bring them to healthcare. Another model is Model for Improvement by IHI, that is Institute for Health Improvement. And in this model, you ask yourself, what are we trying to accomplish? Where are we going? What is our purpose? What is our aim? And how will we know that the change we have made is an improvement? And what is that initiative? What is that change that we will make to have these results? And so once those questions are answered, then you go to the PDSA cycle. You determine what you will do at the planning, and then part whereby now you say, this is the challenge, this is the idea we have, and we think this initiative will lead to a change in it. And so you plan, and then you implement, you do, and you confirm how you're performing. Study is measurement. And then if it has worked, you act by either making that to be part of your standard process or adjusting it. It's called iteration. Iteration is a key principle in quality improvement, whereby I have done a PDCA cycle, SA cycle, and I have learned that this has worked, but if I tweak A or B, it will be more suited for my place. But now we have a change of maybe nurses, so we'll need to do this a little different for us to succeed. And so there are small iterative changes that ultimately lead to a change. And once we discover that we are stable, this is what works. We standardize it and we scale it. So it is a good tool because it can be used for small improvements, and then later they become standardized across. How the lean that we have mentioned in the previous slide, including fishbone, key drivers, the run charts or flow charts, process maps, Pareto, control charts, FMEA. There are multiple kinds of tools. I'm sorry, I may not go to the details, but the tools are meant to explore an issue. And exploring an issue is about getting information from the customer, from the staff, observing. So you explore the issue, and then you're able to communicate. For example, the flow chart, helps us know the flow, or process capability maps. It helps us know where we are wasting time. And then when we sit together to determine what are we going to do, we will prioritize using even the Pareto charts. Then the run charts will help us know once we've started initiating a change, is our dots, our graph coming down? Is it going up? Where are we? And 5S is a tool that is used greatly in QI to ensure that the workplace is safe and easy for people to work in. And I think KNH and basically MOH has utilized 5S and Gemba Kaizen in a big way. As I come towards a close, allow me to mention the benefits of quality improvement, that we have improved outcomes. You remember the outcomes we said are multiple. It could be safer care, could be talking about the process has become cheaper because there are no repeats or redos. The customer is more satisfied, reduction of mortality, happy staff, their backs are not breaking because they're not going round and round in the A&E looking for items. They're all put together. So there could be multiple types of outcomes. Could be just at the level of outputs. For example, if I'm less tired, that is a satisfied staff, but at the end of the day, I've reduced the movement for looking for essential items that should be at one station. Then there's also improved efficiencies of the system, reduced wastage and redo from errors. And it enables people to be more proactive and less reactive, meaning emotionally also it is a good place to be in, to get people who anticipate challenges and prepare for them and not wait to run around when it happens. And so one big quality benefit of quality improvement, as said by, I think there's one QI lady from, I think she must have been from Browns, that one big thing is that quality improvement helps solve complex problems involving multiple people in a systematic way. So it helps to be intimidated with a complex problem, but to know that this problem, there are factors around it, there are processes around it. And so we unpack it and determine what among these can we change. And even if we are to recommend for approaches that are beyond us, what are we trying to see? Or even if it is too complex, but we can monitor, this is the progress. Then you'll determine specific measures and metrics that you will track for the purpose of building your case. I'd like to share some resources of sites that you could look at and get more that can help in terms of further reading. There's IHI. IHI is Institute for Health Improvement. They have an open course, I think, for when we stop being under the least developed countries, it means there is a small fee for it. Then there is a NAHQ, the National Association of Healthcare Quality. They're the ones who give the CPHRQ. They certify quality improvers. Then there is ISQA, International Society for Quality in Healthcare. They have also a fellowship, and I'm aware of a number of Kenyans who've also done ISQA. it is a good association to affiliate to. And I'm glad to mention that I recently was nominated to join the Academy of ISQA. Then there is an Agency of Healthcare Research and Quality. They also have a lot of resources, including patient safety. They have I think a thermometer or a patient culture safety assessment tool. And so these are great resources. So in the future, we hope when such a slide will be being put, that Society for Quality Healthcare will also be part of such. And we're indebted to KNH because it has been part of our seeding ground, for which we are grateful. As a parting shot is that patients are better cared for when they have a voice. So give your patients the voice, and the whole institution's leadership to the front line should commit to excellence. And we should give people space to adapt, to give some variation with their local context, because the frontline person appreciates some things which you at the boardroom or at the Ministry of Health may not appreciate. So it is important that we allow some variation at that level. So communication needs to be very strong on these matters. Thank you very much for giving me opportunity to share. Allow me to open this for any comments and any discussion. Back to Milan.
Thank you, Dr. I think we can use this opportunity to be able to appreciate Dr. for a good presentation from the reviews and the comments that we've seen. There's very good feedback that this presentation was well done. Thank you, Dr. There are a few questions for you, Dr. The first question that we have here, there's a question that is asking the difference between quality improvement and quality assurance.
Yes, Milan. Can you give a number and then we proceed?
Okay, the other one is basically a question: how do you handle online trolls against hospitals and finding their authenticity? The other question is outline KQMH. We have the last one there of this bunch. How do Kanban boards work, and how do they contribute to quality improvement in the healthcare system? I think either he meant Kenyan, the Kanban boards. I don't know what that means.
Thank you very much. Yeah.
Yes.
Great. So I think I should say that quality assurance is it is not it's not an outlier or extremely different from improvement, because the improvement is, the idea is you'd want to have things change for the good, but assurance goes to the level of you're determining whether what you did is what you said you will do, and checking. So it is a close cousin to the quality control. But if you're to put the triangle of planning and quality control and quality improvement, assurance can come in the center, if I could draw that triangle. So what will the assurance do? The assurer do? You will go and confirm that people did as they were supposed to. And so I will give you a mark. I will say on this checklist, you did this, you did not do this. So it is a pseudo, if I could put it, research for this process. So I am measuring, I am determining where you are, and I'm giving you your state of health. This is how you are. But in improvement, I'm finding out who are the people, what did they need, where did we go wrong, how is this process, how does it talk one to the other, what feeds to what, and if we are to make a difference, where do we make a difference? And so it is the putting on the gloves or putting your hands to work. That is what improvement is about. And you can only work with people you understand. And so not that an assurer you don't have to, but for you to support improvement, you are going like a coach. Assurance, I can go with my white collar or with my book and tell you this is where you are as far as this process and this system is concerned. And so I'm saying it is essential that assurance happens, because what does quality assurance do? It helps you to stop everything and to see where are we. It helps you to stop and evaluate. So it is an important aspect of quality improvement. It can feed into how do we need to change. I hope that is clear, but it's also open for any addition. Then coming to outlining the KQMH, I think I will just ask you to go to the website, Kenya Quality Model for Health. It has multiple clauses or domains, and some are clinical, some are basically administrative, and there's an online tool with regard with Kenya Quality Model for Health, and it has various levels. There's a standard, so it is a quality standard. It's a health quality standard. And so there is a standard for various levels, level 6 and 5. There's a level 4, level 3. There is a community KQMH, and the community KQMH has recently been improved to have an improvement part, because standard is almost like assurance. You're almost finding out where are you. We measure your health, but after we measure where you are, we need to change to how do we help you move to the next level. And so the community KQMH, I think, has some good things added to it. You can check MOH website or just type Kenya Quality Model for Health. Another thing you can check is a certification framework. There's a Kenya Health Certification and Accreditation Framework, which also gives you the documents that are supporting the Kenyan scenario. Some are not fully implemented, but it is in the right direction. About trolling for hospitals, I don't know whether I'm an expert to mention anything about trolling for institutions, but what I know is that some people need to put their hands on the ground to ensure that the care given is really addressed and improved. And when we get anything from online, we got to find out, is it true that this is happening? But at the same time, it may be difficult to hold both, to be the one trying to fight online trolling and to do the work. So I think each hospital organizes itself in a manner that will allow some soldiers to do the work, and others will address that. But the voice of the client is important. So where it is malicious, it is another ballgame, but it is good to be open to what is the client saying. And so you go with an inquisitive inquiry. You go to find out, you go to learn, even if you're the head of department, and this has been mentioned, find out what really happened from the people who are there. And you'll be surprised. It's always a learning journey. At times from the kind of customers you have, at times from the kind of situations and stuff and the limitations. And so it is always learning. It is never the same. And so QI is perverse that it gives you tools for everyday improvement in the real workspace. So I don't have authority to give a good response on trolling, but I think my recommendation is allow your soldiers on the ground to do the good work they're supposed to do, while others address those social media wars. And anybody who among the panelists or those who are here, in case there's something they need to type here. Milan, I see there's someone's hand that is up. There was someone's hand that was up. There was Amwango, or they have written a comment.
No, I've not seen any other comment, but I've seen one question. There was a question about importance of accreditation.
Yeah. Accreditation is important because it enabled us to have a benchmark. So you remember we've talked about QI and measurement. So when we say we are measuring, what are we measuring against? And when we say that as a country, we need to have a common good protection of the Kenyans, that when I walk to a facility, I live in Ngumo area, if I rush to a facility in Kenyatta Market, for example, that they will not harm me. And so regulation and accreditation, they give a comfort to that layman, or to that, and everybody becomes a layman at some point, to that person, a suspecting person landing to that facility, that care that is there, if they have been registered by the board, then I expect that I'll be seen by a qualified provider. Now that is where regulation comes in as a minimum standard. And then if I want to go to the next level, in terms of, now we have become a heart center accredited by ABCD standard, then it means I know, just as I experienced this in that other heart center that is accredited, I will get that kind here. And so accreditation is that there is a certain standard which a third party assesses and agrees that, first of all, you have met the minimum standard towards that level of the cardiology services or the renal services. And I confirm that you have health, and we will come back to assess you at a certain point. And these are the standards in that accreditation. For example, A, you should have, let's say, a triage. B, so each standard, ISO has its clauses, KQMH has its own, JCI has its own. And so accreditation in the Kenyan context, international accreditation is used, like we can say that Aga Khan is JCI accredited, but in the Kenyan context, when you talk of the certification and accreditation framework, we have one accreditor called KENAS, Kenya National Accreditation Services. Yeah. So the KENAS is the sole accreditor for all standards in Kenya, and then they allow others now to do the certification, which will be called conformity assessment bodies. However, KEBS uses ISO, which is, I think, is it a Japan or German standard? So KEBS has the ISO, but it is an international standard. So if you go to any other country where they're using ISO 9001 2015, for example, they'll have the same thing that KEBS has, and it is the standard. It has the specific clauses. So it is a group. The quality management systems is a group of procedures, policies, documentation that you adhere to. And it has a certain method of recertifying you. And before recertification, there are processes and steps also in doing that. And so that is a good thing that the country has gotten a framework, but it has not come to the extent that we will say 100% of the country, the facilities are KQMH accredited, that they were last assessed ABCD. And so in Kenya, we have two approaches. We have the KQMH and we have the Joint Health Inspection Checklist, which is safety oriented, but it brings all the providers, all the regulators, a good number from the medical side, the lab technologists, the nurses. It brings them together to do an assessment. And so it also reduces the cost to the facilities, because at times it could be very expensive, and it could inhibit people wanting, it could restrict people being assessed. And so you have places that have not been assessed. And so there are those two aspects. This is also found on the website of the MOH, Joint Health Inspection Checklist and Kenya Quality Model for Health. Thank you, Milan. I think I have made an attempt. Kanban. Kanban is a lean tool of quality improvement. It enables us just to have things that are required in space just on time. I didn't have a slide on Kanban, but Kanban, K-A-N-B-A-N, it is a tool used for quality improvement, and it's all in controlling the flow of stock and flow of materials. And so there are others beyond Kanban, like just in time is also part of it. So there are multiple tools. If you Google lean tools for quality improvement, you'll have a whole list of them.
One last one, Daktari.
Yeah.
One of the participants is asking for further simplification of, because you've put professionalism and quality improvement as separate approaches, especially since negligence directly affects quality. So they wanted to see how that works out.
I'm not getting the question clearly, but at least the important aspect is that patient safety is an aspect of quality. It is one of what we call it is one of the domains. Patient safety is one of the domains of quality. When you look at the one that came from the crossing the quality chasm document. And so addressing ethics and the professionalism of what we do becomes a great tool for it to link it to safety. Why? Because in our the professional conduct gives you, this is how the right practice of medicine is, or as a nurse or as an oncologist, this is what's safe. And so that gives you the codes of conduct. And safety is a principle: first, do no harm. And so we invoke professionalism. And even that is why we have a professional body on quality and safety, for the purpose of that group having its codes of this is how we do what we do. It enables what is it called self-regulations if they're professional societies. And when we come to even up to the regulator, they still use professionalism to say this is the code, this is a doctor of this standing would have done ABCD. And so it is not like a different approach. It is an enabler. It is what we will hold on to make sure that the healthcare provider is doing what they're expected to do. And it comes together with ethics. What is the right thing to do? This is what I should do according to the conduct and the profession of being a family physician. Then also it was ethically whatever right for me to do ABCD. And so even safety is an ethical principle. And so those are just principles and issues that are put together to ensure that that workspace, whoever is there, is able to provide care that works. For example, when you go to the Kenya Quality Model for Health, when you go to the standard, we are told that when it comes to the health professionals, they should be duly registered and they should have their prerequisite certificates or licensures. We expect if you're working in labor ward for this hospital to be healthy, that these people have an emergency obstetric, whatever certification, or at least they have also, or EMACO. The one in accident and emergencies, we expect them that they can do ATLS. You see, all those are nuances towards what is the right conduct of somebody working in that place. And so the quality management, the QMS and the various standards, they link us back to ensuring that these domains are adhered by making sure the provider who is there is a skilled provider who is safe for the patient. Ilan, I think I will allow any other person. I have seen Professor Olwatch is here. He should be the one to answer on professionalism, given that he's been at KMA, which enables, and at the board, there's a nuance of having self-regulation, whereby the various professional groups, why do I belong to a Surgical Society of Kenya? Why do I belong to COGS? So that those groups can auto-regulate themselves. They can have some autonomy to what is correct practice as far as this aspect is concerned. Why do people belong to associations? And see, those are, in Kenya, those are voluntary. But now the regulator will ensure that I will only renew your license if you have this number of CPDs, or if you're, so we assume, we infer that your various associations have helped you get to a safe practice level every other so often. Back to Milan.
Loch, do you have something to say? Your microphone is on. Joseph Loch?
Yes, can you hear me?
Yes, we can.
I just wanted to thank you for the excellent talk on this healthcare quality, which has been my interest. I'd asked Dr. Kutoy just to explain more what the ministry's outline of Kenya model of healthcare quality is. You talked about healthcare quality in general, but there must be a mix of healthcare quality model, which was, I think, promulgated in 1922 or 21.
Yes, Prof. That was done in the, I think in the 50s by one Dr. Tom Boyer, and not in the 50s, in the 70s or 80s. The Kenya, the first, or the Kenya model for health, before even it became KQMH. Then in 2015, thereabout, it was revised. And so it had 11 clauses, and only the last three were clinical related. And so the others were around referral, health financing, were around governance, leadership, materials. So when the revision happened in 2017, 2018, the idea was we need to move this model towards it being more clinical. Because remember, it seemed like it could fit for any industry other than this small part that had 3 clauses that were related to health. And so they expanded it to include now the emergency care in the, like now the physicians worked on asthma, diabetic, whatever crisis, and in all those, the nuance was to say, you should have this kind of staff, you should have this kind of equipment, and the processes should be like this. For example, for asthma, what should you have in terms of the capacity of the staff, then the the trays, what should they have in that accident and emergency, and then coming to the process. Do you have a defined process? And so KQMH unpacked that.
Yeah.
Yes.
See, originally, most healthcare quality assessment was based on the profession, medical profession, but now, it's the reverse. It now goes to the patient-related outcome, as well as the community and the family, who are more important in giving you assessment of healthcare quality. So you should more emphasis on healthcare quality. I mean, the patient-related outcome, the community impression of your medical services, the skills, and of course the medical knowledge, of course, is very important and vital. But they're not the first. In the middle, of course, you've got healthcare facilities and the staff who work there, and the quality, the way the nurses and doctors dress or look, and the way they treat patients. This is the quality. But another thing about as you on the platform, health quality improvement depends on data analysis. Because you can only improve what you have measured. You said yourself that you have to measure it. But the problem is, in our situation, we don't have very good system for collecting and analyzing your data. So you may not know what you are measuring and how it's going, and then you have to, how to improve it. So first and foremost, you must improve our data collection and analysis. You can collect a lot of data as you do here, but if you don't analyze it, then the data is just like garbage. So you must have a system of, even if you're analyzing how the patient, how much antibiotics is wasted, the quality depends on not using too many antibiotics, not doing unnecessary tests. But if you don't know, analyze how many useless tests are being done in a hospital or in a community, or how many unnecessary prescription antibiotics, then you cannot improve the quality. So that also impedes the cost of healthcare, which is a very important part of the quality of healthcare.
Thank you, Prof. I think you're on point. Actually, the KQMH has an outcome part whereby they look at including mortalities and the patient satisfaction. As a country, we are starting to learn how to use what is called patient-reported outcomes. And I think the professional societies could help us by doing patient-reported outcomes for their thematic areas. And then we start having a learning curve on how to use PROMs as a country. So you are very much on point that outcomes are a part of what is in the Kenya Quality Model for Health, including mortality and satisfaction outcomes. So, and the misuse, underuse, overuse, all those are gaps that could have been on this slide on quality improvement, reducing overuse, misuse, or underuse of any, because that goes towards wastage and efficiency and money. So still, it can get itself somewhere. So I think your points are well taken. Milan, do we have any other person who wants to give a comment? Whose hand is up?
So far, I have not seen any other. I think we have done justice to this presentation. Thank you, Daktari. Thank you, Prof, for your additional input on importance of that. We want to thank you. And Daktari, I don't know if you could be able to say something about CPD. I'm seeing a lot of questions about CPD, how they can earn their CPD.
Yeah, I think Dr. is Mandela here. Mandela can give a response to the CPD because it depends on the cadre, on whether the pharmacists or the nurses, they all have a different approach. So yes, Mandela, you can give that response, Mr. Mandela. There are two hands that are raised for Victor and for Peter Ndirangu. maybe as we get the response for the CPD, Victor Nahungu, do you have your hands raised? Or they are
Victor,
unable to.
you can go first.
Maybe they are not able to unmute unless Mandela helps them.
Peter, your hand is up.
Okay. Peter and Victor, you've been upgraded. You can talk. And Joanne Kagema, maybe we can have those three.
Hello.
Yes,
Yes.
Joanne.
Yes, John.
Thank you, Dr. Kitoi, for the presentation. But now the other thing that I'd like even to consider is about when we come to the issues of the special groups. What do I mean by the special groups? The people with the disability, live around the physics, the neurodevelopmental disorders, in how the institutions may handle the cases or our point of care from the entrance advent to the wards, and how to identify the needs for such kind of people. Those that cannot be able to talk to them, like when you have an autistic person, you have a DS, a Down syndrome, you have a cerebral palsy, and sometimes you miss some few of the things. So to be able to have a good quality care for them. So we should come with a way, because even where we trained, I don't think even the nursing that is now today, we were never taught about. But we need to have to come with a way on a way on how we can handle such kind of people.
Thank you, Joanne.
Yeah.
Thank you. So, and the other question, so that we take the three of them, that was from Peter. They have dropped, huh? Or they didn't plan to raise their hand. Great. Did Peter and the other type anything on the Q&A? So thank you, Joanne, for your concern. If there's something that we have picked today is that quality improvement is for complex issues involving multiple people and multiple players. So like just the statement of we need to address people living with disability, that in itself is an equity issue. But now a QI person will say, what is the pain point? What is the gap? So you've mentioned one gap is in terms of communication, that we are not communicating effectively, sign language and such. And so that becomes now the question. But in case there are other issues, for example, we have disability mainstreaming and issues of trying to look at mobility within our various places. How does someone with disability, let's say, reach our endocrinology clinic, for example? So there are real things. So one thing with passion that you have is that we unpack what that means and who are these players, whom are we bringing on the table? What measurement are we saying, as Dr. Locha said? So what are the pain points that they're having, and is it measurable? Out of this number of patients with this issue, these were not able to do ABCD, or in their journey, when I map this process, here is a bottleneck, here is a bottleneck. Why? Because of their disability. And so equity is a quality domain, ensuring that there is a highest standard of quality of care for all. And so when I am left out because I am specially gifted in a different way, then it means that there is a challenge. So we pick up that, Joanne, but at the same time, ask you to help us unpack it in another forum with the respective players, but as healthcare quality KNH, for what applies to KNH, we are open for discussion and guidance on can be on that table, or where does this fall? Because there could be some things that have specific departments that should address. And so what help do they need for us to create a story using data in regard to this? Thank you. I think we have come to 3:31. Unless otherwise, allow me to say thank you for having me here. Dr. Rhoda, did you have anything? Or yeah, so thank you for.
I don't. Thank you.
Okay, thank you very much. Allow me to hand this back to Mr. Milan on behalf of KNH and Society for Quality Healthcare. I'm grateful that we got this chance to share with you this information.
Thank you, Dr. Okutoi, for that presentation. And I think we can end it there, and participants can be able to exit the platform at pleasure. Thank you very much.